Welcome to Pedo Teeth Talk, brought to you by the American Academy of Pediatric Dentistry, a podcast show that delivers cutting-edge ideas for the professionals specializing in pediatric dentistry.
Thank you for tuning in to Pedo Teeth Talk, where we bring you the contemporary issues important to you and your practice. Brought to you by the American Academy of Pediatric Dentistry. I am your host, Joel Berg, and thank you to our Pedo Teeth Talk sponsor, Hugh Freedy, for helping us bring you great content. We couldn't do this without them. Visit them at www.hughfreedy.com. That's HU-FRIEDY.com. We're here today with Dr. Roger Sanger to talk about surgery centers or surgicenters. Dr. Sanger is both a noted clinician and successful businessman. He has had a career that spans academics, private practice, with entrepreneurism in both. He attained the rank of tenured full professor and chair of pedo ortho and has written 2 clinical books and hundreds of scientific articles and book chapters, as well as being an assistant dean for CE and hospital affairs. Upon leaving academics, he co-founded a group practice that became, over the next 3 decades, one of the largest regional multi-doctor, multi-facility pediatric dental groups in California, with over 150 employees, 2 surgery centers, a hospital-based practice, and an orthodontic-affiliated practice. He co-founded a 501c3 not-for-profit foundation with private great support that established mobile school-based dental clinics. Roger co-founded with his group one of the first management services organizations, MSOs, in dentistry, the precursor to today's DSOs. He sold his share of the group practice internally in 2011 to devote more time to other dental entrepreneurial activities. He has since co-founded the Institute for Pediatric Dentistry, which designed and produced hands-on SimLab education, training our newer practitioners in the game-changing technologies in pediatric dentistry to do care better, faster, and easier. Dr. Sanger is Executive Director of MCNA Dental Plan of Idaho, the contractor for the State of Idaho Dental Medicaid CHIP program as well. He's a life member of the ADA and AAPD, and we're here to talk about surgery centers with Dr. Sanger in the midst of this COVID crisis where the issue of getting access to general anesthesia has become almost a crisis in itself, as we're seeing on Little Teeth Chat and other blogs. So, Roger, thanks for being with us today, and I really appreciate having the expert talk to us about this important issue. I want to get right in and say, what is a surgicenter anyway? Tell us, what does it mean when I say surgicenter?
Oh, first, Joel, thanks for the invitation, but that's a good leading question. What is a surgery center? You know, really every dental practice is a surgery center because we do surgery. We're a surgical specialty, and we've got some interesting statistics that are kind of involved right now in making decisions on that particular area of surgery. So whether it's pulp therapy, restorative therapy, oral surgery, whatever the case may be, surgery is important to us as a specialty. Surgery center primarily happened in the 70s, Joel, because physicians faced the same dilemma that hospitals did not have enough physical facilities for them, and as their surgical specialties grew, they had a difficult time getting all their patients in, whether they be elective patients or emergency patients. So along about 1970, someone came up with, well, let's either do a hospital-based surgery center, which the hospital said, well, gee, you already have operating rooms. Why do you need a hospital-based surgery center? And the next thing was, well, why don't we have a office-based, or what we call, outside the hospital facility to do our surgery, and primarily elective surgery. So fast forward today, we have over about 10,000 surgery centers in medicine. About 90%, Joel, are still owned by physicians.
Interesting.
With about 50% of those physicians being investors. So there's a great financial thing there. About 3% are owned by hospitals. So hospitals are starting to look at the fact that, yes, they make money with their OR situations, but they also are looking at something that many hospitals are doing, and that's either an attached or a detached surgery center.
So they've been around for a while, these things, and I think you were an innovator, as you are in many areas. And how did you develop your own need for your group to have what you deemed a surgery center back when you started it?
Yeah, so that's a good question. A couple of things and a lot of people think that pediatric dentistry is rather homogeneous, and it really isn't. We're more heterogeneous in that some practices have very low caries, as you know. Some practices have a lot of caries, and in our particular case, because we did see the Medicaid child, the CHIP child, the PPO child, our practice was a higher caries rate practice than that. So it's taken COVID to kind of maybe wake some of us up that we had. I hate to use the term we got shut out of the hospital, but we did.
Well, that's what we're here. We're hearing that.
Yeah,
we're hearing that from a lot of members.
Yeah, I'm being shut out because let's face it, dentistry doesn't bring a lot of cash into the hospitals in terms of their operating room. They're not complex cases. They don't have a high facility fee attached to that operating room. So, it's tough today to even get on a hospital staff, let alone get some time in the ORs. And that's based upon the hospital either having a attached or detached surgery center themselves or not. So the fact that surgeries have increased, the population has, we keep people alive a lot longer. If you ask some of our colleagues in orthopedic surgery, they're doing more back surgery, knee surgery, hip surgery, that kind of stuff. So we could go through, Joel, the deluge of our surgical specialty colleagues, and, they just need surgery time. And they're going to, if that means bouncing a dental case, well, that's okay. So that tradition, I don't think started because of COVID. It's been exaggerated because of COVID, but
right.
it started years ago when many of us said we want to take a lot of our cases to the hospital. So that gave our group the impetus to say, is there another means out there? And therefore, Joe, we did look at our own surgery centers, which, if you'd like, I'll expand on in terms of how we set those up.
I will. I am going to ask you about that.
Okay.
But it sounds like, to recap what you just said, that the availability of OR time at a reasonable cost and in a way that you could do it in a facilitated manner in certain number of cases a day didn't exist in hospitals, and that's one of the main reasons you developed yours.
And the fact that hospitals, in terms of their surgical suites, are slow because they need to be slow. Many of the cases that are medically compromised, physically compromised, behaviorally compromised, that kind of stuff. So, we found out that many of our cases we were taking to the operating room, we really could do in our practice if we had a streamlined operation to deliver good anesthesia with, like I say, better, faster, and easier dental care.
So it sounds like, if we rewind back to when you trained and when I trained, there was no surgery center. There was no office-based anesthesia. Everything was done in the hospital. Even the healthy kids, we treated them in the hospital. Sometimes they were admitted the day before and discharged the next day, just like with third molars. But, as medicine has advanced, that's what you just told us, we too are following and recognizing the vast majority of the children that we treat for these reasons are healthy or otherwise healthy, and their mouth maybe isn't, but the rest of them is, and they can be treated in a what you're calling a dental surgery center. That's
correct. I mean, I think that, we see that behaviorally today. So I always feel there's going to be a place for the interdisciplinary approach at the hospitals, but we've pretty much proven that with our model that you can see a lot of kids in your practice if you have another streamlined entity called a surgery center. So
yes,
and I think that's a marketing effort too. I mean, parents today, you and I've talked before about same-day care, and now the popularity is one-visit care. So I know a lot of parents that say, doctor, we can't, I know Johnny's a good patient, but can he withstand 4 and 5 visits of coming to your office? Generally then after school with the use of nitrous, that's fine. But those kids are stressed out there. So as you and I know, after the second or third visit, they become very poor in terms of their ability to cope with more visits in terms of dental care. So
I think COVID-19 has also accelerated and expanded the interest in same-day or one-time care because of the reducing number of exposures to an environment.
Yeah, I see parents today that really want same-day care. And that could mean, let's say, your child needs some sealants, and instead of scheduling that, then get your hygienist and that team and do the sealants in that same day. We can do a little bit of that with respect to restorative care if the child just needs maybe a single tooth or something like that. But I'm
Right.
talking about those high caries children, Joel, that comes to your practice and you look in their mouth and they got 5 quadrants of work to do. So, that's where the parents really appreciate what I call one visit care.
Yeah, no, that's fantastic. Now, speaking of surgery centers, there's a lot of confusion, as you alluded to. And can you tell us about the different models that you looked into and what are the different models of surgery centers?
Yeah, and we see those models in pediatric dentistry today. So it's a great question for those that are considering what model is best suited for me. I go back to the old days of every dental office had a quiet room, and then that morphed into really that was a place that the kids I don't take to the OR, I'll do in the quiet room. So that's metamorphosed today into something a little bit more different. And so let's take a look at maybe the whole surgery center conglomerate, as I call it, and that can be. Some pediatric dentists right now are already established with physicians, and they may have a metropolitan or regional surgery center that they own and where they can take their cases to. Then you have some of the larger, maybe pediatric groups that say, we'd like a surgery center, but we like it just for ourselves. We don't want to have it. We don't want to have the same thing we faced in the hospital that people are going to tell us, well, no, you can't do this on that day because that's so and so coming in, et cetera. So what we faced is we're looking at some models that may not require quite the extensiveness of the investment potential. We wouldn't have to go outside of our practice. We could do it internally. And so we could still keep the same concept of a surgery center, but then we would not be looking at the requirements that are out there for accreditation, certification, and state licensure. So those 3 things enter into the fact that, Joe, there's just a lot of requirements if you decide to have an accredited, certified, licensed surgery center. And people do that because they say, well, then I can bill for the facility. And certainly that's the case if you're an investor in in a surgery center. You might not use it a lot, but you may say, well, I'm going to I'm going to build a surgery center with some colleagues and I'll invest in it. And so, you look at the fact that I don't use it that much, so I'm not using it for those high caries kids in my practice. I may be just using it for the fact that, occasionally I'll use it, but I can invest in it. So
Right.
The facility fee becomes an important aspect because the facility fee can only happen if you become accredited, certified, and have a state license. So,
that's
yeah.
I was going to say, right, the facility fee thing, and I want to get into that. Right now, I want to take a moment and pause for a word from our sponsor.
Hugh Freedy is the global leader in dental instrument manufacturing, offering pediatric restorative solutions that keep you performing at your best. For more information on Hugh Freedy products, visit www.hughfreedy.com/AAPD-crowns.
We are back with Dr. Roger Sanger talking about surgery centers. And Roger, we were talking about accredited versus non-accredited. And, I think as you were describing, people think that they may assume that accredited may be preferred because you get the facility fee, but the constraints on a facility that's accredited make the cost of making it a facility more expensive than the small amount of revenue you get from the facility fee. Is that an accurate statement?
That's an accurate statement, and our concept was, since we weren't going to have external investors, it was just going to be for our group itself, that the first surgery center we did was just for our group, and we basically didn't care about the facility fee. We cared more about doing the dentistry better, faster, and easier. And the more children we could do safely in that particular surgery center, we could make the money off the fact that we were able to do maybe 3, 4, 5 quadrants in some really short amount of time, and we didn't have to worry so much about did I have a nurse that I had to also worry about that salary? Did I have a lot of architectural design issues I had to incorporate? And more importantly, how can I use that surgery center in the afternoon? So, with our surgery center being designed just for us, Joel, we were able to not only do cases in the morning, but in the afternoon when you traditionally don't do surgical cases, that part of our office became another group of chairs that we used for exams, recalls, minor op, stuff like that. So it just made more economic sense for us to not worry about accreditation, certification, and state license. We were going to incorporate all those safety features anyhow. We just wanted to make sure that we wanted to do our surgical cases, restorative cases, pulp therapy, whatever you want to call it, the best we could in the shortest amount of time, but with safety. And so that also tied into the fact that we became a non-opioid practice. We didn't use any diazepams that were long in, we call long out. So our practice pretty much went to the conversion to what the AAPD is probably the most popular protocol right now in pediatric dentistry, and that's Versed coupled with an antihistamine if we needed it.
Right.
Why? Because Versed as a benzodiazepine is a great no memory drug. So we could maybe use a little lighter sedation, and if the child was fussy because it was a behavioral issue child, well, they wouldn't remember it. And
Right.
the
retrograde amnesia part.
Those factors all entered into the fact that, we wanted to be no opioid. We wanted to control our own destiny in terms of the protocol we use. Now, I must say that our surgery centers, did have the ability to have anesthesiologists come in, and I see that's a plus because right now, as you know, we're producing more dental anesthesiologists than ever before. And a lot of us say, well, gee, I may want to use a little higher level of sedation on this patient without me being the anesthesia provider. So,
you have both options there, yeah. And I think what you've done here, what you've shown, Roger, is because when most people think of a surgery center, they're probably thinking about a separate anesthetist, anesthesiologist, or someone else doing that part, and you doing the other. But what you did, and what you were the most prominent, still are, in the field of sedation, of doing the method you described. And most of the treatments done in your surgery center were actually oral conscious sedation, not general anesthesia.
That's correct.
However, you could, if one is thinking about this in terms of general anesthesia, the same practice business models that you developed for your surgery center, the idea of separating out the surgery from the medicine part, the internal medicine part of dentistry, is what you're talking about. It enables you to be flexible and do all these different things.
Yeah. I mean, a surgery center for us, that's right, Joe. We could do oral conscious. We could do IV or GA with an anesthesiologist coming in. Plus, in the afternoon, that center could be converted to a regular dental office. I mean, I see so many surgery centers today. They're really nice. They look terrific. They're one operatory rooms the size of a basketball court, and in the afternoon, they're just quiet. And so they may waste 1,000 square feet, 1,500 square feet, just because they go for accreditation. They have to have the wider aisles. They have to have all the architectural design necessary for accreditation. So you're correct.
I think I like the concept of surgery center being at a high level that you describe, because you're talking about a space that is primarily, although as you've indicated, can be used for other things when there's downtime, is dedicated towards surgery. Now, the mode of managing the patient may be different. I worked in a practice here in Glendale where the owner is not only a pediatric dentist, but anesthesiologist, and he offers not only general anesthesia and the practice oral conscious sedation, but also IM.
Yeah.
So it's sort of a short-term GA, deep sedation with ketamine. And, and I think if you have a surgery center concept, it enables you to do all those different things, you as the anesthetist, or in many cases, sometimes, depending on the state regulatory situation. Having an anesthesiologist. Every state's a little different. So
That's right. And I was IV trained, but I also like going to the hospital. I just felt that I was taking too many kids to the hospital that didn't need to be in the hospital. I was not making any money in the hospital because, by and large, when you take a child to the hospital, the operating room, it's a slow case. I mean, they have to have the nurses come in and all that stuff. And so, that means a lot of us in the early days, as you know, Joel, said, well, that was our day off. We would tap Wednesday morning, Friday morning, and we'd go to the OR. Why? Because you couldn't make any money. Then you'd hit the golf course in the afternoon.
Yeah, that's you can't do that in Arizona. It's too hot.
Yeah, you can't do that anymore.
Right.
In terms of that. So the model has changed. I think what you and I are talking about is a model that can suit whether it's a solo practice or a multi-location practice. In our situation, it was the latter. We just made sure that we had 2 offices that were strategically placed that had surgery centers, that from the other offices we could refer them to that surgery center.
Yeah, so it sounds like Roger, that a surgery center is never going to replace those 20% who need to go. They have their ASA 2+, 3s, 4s, or they have other reasons, post-operative management, a large kid with autism, who needs post-op management. I think those are never going to be replaced. But the 80% who are otherwise healthy, the profitability you're telling us is always going to be there with a surgery center compared with a hospital where it's never really going to be profitable.
That's right, and now we find out that that's not only not that profitable, and I hate it's okay to use that word in our business. I mean, we found out that COVA, the word profitability is not a bad word anymore.
I think sometimes your model, speaking of our safety committee, which has really looked at all aspects of safety for the APD, and I think we're one of the most up-to-date disciplines in that area, is always looking at practice methods and how we can be safer. And it sounds like, one of the most important part of safety protocols is having protocols, having systems, having processes, efficiencies.
Yeah.
And you've defined those as part of your surgery center concept.
I mean, we have the same. We have emergency drills. We have emergency equipment. We have the protocol for an emergency. We have the trained personnel, et cetera, et cetera. We have the latest in monitors. So you can't just say, well, that surgery center that's not accredited and not certified or not licensed by the state, that's not a safe center. Well, again, I'll go back to the definition that, surgery centers by and large were meant for elective surgery and ambulatory patients that did not require a lot of care after you did the surgery. So I think the marketing is also important because, yes, we became, well, that's that practice that sedated every kid. And no, we didn't. A retrospective study we did of our group said that we sedated less than 20% of our patient population, but over 40% of our income came from those surgery center patients. Why? Because we did them in one visit. And the parents loved us. I mean, when you have Medicaid PPO parents, they don't want to spend a lot of time away from work, and they don't want their child to be absent from school a lot. So, although you see on the side of the building of the 2 surgery centers we had, it says, Pediatric Surgery Center. That was for marketing purposes. I mean, that's why I said in the beginning, a dental office, even if you have one little quiet room, that is your surgery
you're right.
center.
It's a conceptual framework is what it is. Yeah, and that's right. So I want to get into our last question in our limited time. This has been amazing having this conversation. And before I do that, I want to tell our listeners, if you haven't heard already, go to the Pedo Teeth Talk and listen to the podcast with Steve Wilson. We just posted on oral conscious sedation. And then a couple months ago, I had the chance to check in with Jeff Brownstein. As I mentioned, he's a dual-trained pediatric dentist anesthesiologist talking about office-based anesthesia. And those fit in very well with the conversation with Dr. Sanger today. So, Dr. Sanger, I have to ask you my last question, which is about the trend. Where you've talked a lot about that. You know where we came from. Where are we headed? Where's the trend related to surgery centers? And I want to hear what you have to say on that.
Well, first off, I think the trend is going to be away from the solo practitioner and the solo dentist and the solo office. Why? Because as you build doctors and you build maybe other locations, you can have a greater management staff. You can have a lot of the new technology that you can afford because that's split up over a lot of different practices. So I see that as a trend. I see that with the caries rate not decreasing appreciably, and the fact that I just read that today 50% of all births in the United States are Medicaid. So bless their heart. most of our Medicaid kids and our CHIP patients and some of our entry-level PPO patients have a lot of caries. And so the caries just have not gone away. But I think with what COVID has brought to the forefront is same-day care and one-visit care, which I think becomes very popular with parents economically and just lifestyle-wise. So I see that no matter whether you are saying, well, I still want to be part of a external physician, dentist, surgery center, that's fine. Or whether you say I want to bring in a dental anesthesiologist now that they're a specialty of dentistry, which has helped their credentialing a lot and gotten them more ability to get their fee for service with both health plans, dental and medical. I just see a complete emergence, so to speak, with our specialty, pediatric dentistry, which by and large is a surgical specialty.
Yes.
And I see as the entities grow to solo practices, to then group practices, to group practices with multi-locations, with multi-doctors, I see a tremendous opportunity for entrepreneurism in those particular groups.
Yeah.
You and I talked about the fact that I see down the line more pediatric DSOs coming on board as more and more of these practices are growing beyond their ability to manage them and partner with other practices that are growing, and I think we'll see probably more of that happening within the dental anesthesiologist field. So
I agree with you. Those are the trends, and I think whatever actually happens, your advice is extremely valuable, and I urge everybody. I know, Roger, you're one that is always willing to talk with others, and you've done that on Little Teeth Chat, and that's been really valuable to members, and I think if anybody has any additional questions, I know you'll be open to addressing them. And I think that as the specialty evolves further, we are a surgical discipline, but we're also evolving in medical management too. But the idea of a surgery center is going to become more important as we distinguish ourselves in those two areas. Therefore, having a surgery center makes it even more important to underline the value of process and systems and safety. Roger, thank you so much. You're an expert. You've accomplished more than, anybody who's accomplished as much as you have across the board in dentistry and especially in pediatric dentistry, and you're a role model to so many of us, and I really appreciate you taking the time to talk to us today on Pedo Teeth Talk.
Well, those are such nice comments, and I appreciate the time that I spend with you, Joel. Thank you.
Thank you. And thank you to our audience for tuning into Pedo Teeth Talk, where we bring you the contemporary issues important to you and your practice. Brought to you by the American Academy of Pediatric Dentistry. We'll see you here next time.
Do you need additional CE hours but don't have time to travel to courses? Did you attend annual session and want to listen to the audio recordings? Check out AAPD's new Education Passport. The redesigned and improved Education Passport is AAPD's online learning center, where you can earn CE and listen to audio recordings from all of our continuing education courses and more. Visit educationpassport.aapd.org for more information. For 10% off any product, use discount code TEETHTALK in the Education Passport store.
Pedo Teeth Talk is brought to you by the American Academy of Pediatric Dentistry, the show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry. If you have any questions or comments, please email info@aapd.org. We welcome your ideas for future shows and guests. For more information on the American Academy of Pediatric Dentistry, visit aapd.org.